Hi, everybody. Welcome to the second webinar in this three-part series on highlighting in-progress efforts from leading healthcare organizations on measuring return on investment for their social needs initiatives. This webinar will feature a pilot program from Kaiser Permanente on measuring ROI for their high needs community. My name is Marie Hubbard, and I'm the project manager for the California Improvement Network, also known as CIN. For those of you that aren't familiar with CIN is a network of quality improvement leaders focused on innovation in healthcare. CIN is a program funded by the California Healthcare Foundation and administered by Health Force Center at UCSF. A few pieces of logistical information. Everybody will remain on mute for this webinar except for our speakers. If you have a question, please feel free to ask in the Q&A function at the bottom panel of your screen. We will get to as many questions as we can within the hour. This webinar will be recorded. Now I will introduce our speakers. First, our facilitator, April Watson. She's the Director of Practice Transformation at California Quality Collaborative, and she's also one of CIN's managing partners. Our presenters are Adam Sharp, emergency physician and research scientist at Kaiser Permanente, Southern California, and Artair Rogers, the West Coast Partnership Manager at Health Leads. I'll now pass it off to April to get us started.
Great, thanks so much, Marie. So I'm not sure if folks are seeing slides advancing. There we go, awesome. Yes, it's my pleasure to facilitate the second in this webinar series on ROI for social needs. And I actually want to just go ahead and let Adam and Artair get going because I know they have a lot to cover. And I also want to make sure that we are able to have time for questions and conversation with our presenters and also among the participants. And I know there's a lot of you today on this webinar, so we're really excited to have so many folks joining. So I think, Adam, you're going to be first up to kick us off.
Great. Thank you, Marie and April, and thank you for allowing us to speak a little bit about our experience in trying to identify and address social needs. Just a brief background, if you're not familiar with Kaiser Permanente, in California, we have two regions, North and South, and I am part of the Southern California region, so that's who we'll be talking about today. For those not familiar, we're an integrated health system, so primarily our health plan, hospital, and physician group all work collaboratively together, which is a little bit of a unique model. For comparison, we have about 77% of our membership, of the 4.5 million members, are commercially insured. About 13 or so percent are Medicare, about 10% are CHIP or Medicaid, and then the rest is charitable coverage for the patients that we see. You'll see this on the graph here. We have a variety of hospitals that are owned by us, 15 of them, a few hundred clinics and medical offices, and a number of employees. And so that's kind of the setting that we'll be discussing based on what we do later today. I'll pass it over to Artair, who was with Kaiser Permanente Southern California when we initiated this, and unfortunately Health Leads recruited him away from us. So he has a great perspective on both of the organizations in this collaboration.
Health Leads is an organization based in Boston. The organization aims to address systemic barriers that prevent individuals' ability to obtain an optimal health status, which really centers our work on social determinants of health. The organization has a national model, but also have regional teams. Even though I was recruited away from Kaiser Permanente, Southern California, I'm still located in Southern California, and I am a part of the California or West Coast team for Health Leads.
And we're going to get into a little bit, since this particular seminar is about calculating a return on investment. I just want to mention from Kaiser Permanente's perspective, though we're an integrated system, I've been here about 5 years. The other health systems I've been associated with in the typical fee-for-service model, all of them, including our organization, have addressed social needs, but it hasn't really been a systematic approach, save from the county health system, of which I did my residency at, because they were obligated to do so because the majority, if not all of their patients that were seen needed to be addressed. So one of the initial things with coming up with a return on investment is how we approach it and what is the outcome of interest. Many, for very valid reasons in the past, for folks, for example, who had food insecurity, if we connected them with food, that seemed to be sufficient enough. And I think if you're a distributor of food or a community organization that's your primary aim, that's certainly a very important outcome. As a health system, we don't necessarily represent a food distribution service, and so we hope to use an outcome that we were more familiar with. And our first question was about costs versus utilization, and I'm going to talk a little bit about that. One of our senior biostatisticians, John Adams, who if you're in the research world will know is kind of a world-renowned biostatistician, and helped to convince us that costs was not maybe the best metric, only because we know that we don't control costs as part of any intervention that we may make, and costs may change entirely unrelated. Whereas utilization, we can attribute costs, but we know what it is to come to the clinic, we know what it is to come to the emergency department. So we ended up landing on utilization as our primary metric. Not because we believe that is what's most important, but because we can measure it, and our system was used to it. We can capture it with validity and accuracy. I've listed here a variety of other potential outcomes, and we talked a lot about this over the course of this pilot project. Mortality would be wonderful. We would love to see a change in mortality. I think the timeline is not necessarily set for that. Hemoglobin A1C and hypertension. Some of you may be familiar with the work similarly related to health leads that Seth Berkowitz has done in Boston, and his work was able to show some improvements in some of these metrics. The others, the patient-reported outcomes that we think are important, like quality of life or self-efficacy, are things that we did not have readily available, and we really didn't have the resources to follow and track these over time. I will say that we did some qualitative work, and we did some patient interviews as well as some focus group interviews. And this was an overall satisfier. If patient satisfaction is the metric of interest in terms of identifying and addressing needs for health systems, we feel that we were able to certainly land on patient satisfaction as something that this does, even for patients that don't have social needs and have never had social needs. They appreciated us asking, and I think there may be something to that. In addition to that, the staff satisfaction. For those of you that work in the health system, many of us that may be physicians or healthcare providers, a main, I think, contributor to dissatisfaction is when we see the needs in the lives of many of the patients we may take care of, but don't feel like we're well equipped to be able to do anything about that. And so these interventions, I think, when we talked to our staff here, because we also did interviews and surveys with them, they were all in favor and appreciated the help. I will also mention, I think it's really important when it comes to return on investment. My understanding of the evidence is we don't really know the timeline with which addressing social needs are going to affect patient outcomes. It would be nice to know that by addressing food and transportation needs that we're going to reduce, for example, 30-day readmission rates. And we believe that these may have some very important long-term effects. But typically ROIs are more in the short-term timeline. And so I think that's a big question that we were left with. We ended up following up for 14 months because we had that just happened to be what we had in our timeline. But that's not because we felt that was the exact time that was needed. But we followed our outcome. Our primary outcome was utilization, and our timeline was just over a year because that's what we had. That was what was feasible for us to do.
So this is April, and I apologize because I seem to be having internet issues. I keep getting dropped and I'm rejoining. So I'm crossing my fingers that I'm going to be able to stay connected here for the rest of the webinar. But I wanted to jump in really quickly. One, to ask a question, and then also just to create a pause so that folks that are on the line can ask questions using the Q&A. And I think there might be a couple coming in, which Marie will tell us about. But I'm gonna go ahead and ask and apologize if you answered this while I was trying to reconnect. So I'm curious about a bit of the backstory. So why, at this point, like what prompted Kaiser Permanente at this point in time to decide to kind of undertake this work? If you could say a little bit about that, or ignore me if you answered that while I was reconnecting.
No, I don't think I fully answered that. So thank you for asking. I don't think it was any one event that has launched Kaiser Permanente into a more systematic and prioritized vision of what social needs contribute to. I think in the same way that Medicare Advantage is now, beginning to pay for the social non-medical needs because we see how much it contributes to the health and well-being of the people we're trying to help. We saw that too. Kaiser we like to think of ourselves as a leader in terms of, compliance and the typical HEDIS metrics and hemoglobin A1C. And just the truth of the matter, anyone that's ever seen, what leads to contributing to health from a public health perspective, we know that healthcare is a very small slice of that pie. And that if we wanted to actually move the needle in a meaningful way, we have to look outside of medications, therapies, and surgeries. And really that speaks to getting into this social non-medical world in a more meaningful and systematic way.
And to add, April, specifically for this pilot, this was kind of birthed out of discussions from social workers, case managers, nurses who were on case management teams looking at high utilizer populations. So individuals who had multiple chronic conditions and who were utilizing the emergency department or were being admitted to the hospital quite often. We saw that many different individual healthcare centers were developing their own kind of homegrown, they call them intensive case management programs. When we interviewed the case managers on kind of what were challenges with their program, they often stated that there was this black box that they could not address, which is something that Adam alluded to earlier as being like a staff dissatisfier, that a lot of the social needs, they didn't have the resources or the tools to both one, ask about them, but also be able to address them. So that's how we landed on this particular pilot.
It looks like we have a few questions in the chat box. One of them comes from Jennifer Hone. Who on your staff owns these addressing social needs efforts?
That's a really important question. So we will talk a little bit later, and I think Artair will get to what we did in our pilot work. And there was a specific, we called them navigators, that were actually health leads, employees that reached out telephonically to our members. And I will just, the honest and generic answer to this is no one owns this. It's everywhere, and sadly that also means it's nowhere, because it's partially the physician, partially the nurses, partially the frontline staff, partially, social work certainly is involved, but their certification and qualifications allow them to do much more than that. And so it depends on the medical center and the clinic that you look at in our system. And so at this time in our organization, there's not any one entity who owns this space.
And there was just one more question before we move on. I think it's relevant to what you spoke to earlier, Adam. Is there anything to be said about acuity level and the opportunity to demonstrate ROI? In other words, is it more feasible to demonstrate ROI for persons with high acuity and who are more sick?
So yes. So as Artair alluded to earlier, so we chose to look at our predicted high utilizer population. For that very reason, they're patients who have a lot of comorbidities and a lot of medical complexity. We also learned they have a lot of social complexity, which contributes to that. We specifically target that group because we felt that any small effect size in terms of improving health would potentially be identified in the utilization patterns of those patients going to the emergency department or hospitalization. So that's how we approached it, and I agree. I think looking at special populations, whether it be those that are hospitalized, and therefore you can look at a readmit rate because you've chosen to prioritize hospitalized patients, or specific groups that it helps you identify the outcome of interest. If utilization is that thing, then you want to go after first those patients that are high utilizers, because that might be the group you benefit most. And that's kind of what we did, at least in this pilot.
Yeah, so Adam gave a lot of background around kind of the rationale behind the pilot. And April, I hope we answered your question around a little bit more in depth about the rationale of the pilot. Essentially, we chose several social domains that we wanted to ask this predicted high utilizer patient population about. One, this is a collection of just insight that we heard from case managers and other folks who worked within these intense case managers of social needs that they were hearing. And then, I think when you get a lot of people together to work on a pilot, there are a lot of special interests. So essentially, we started asking about everything instead of maybe in some social needs pilots, we've seen 3 to 4 questions asked. I believe our screening tool was close to like 12 questions and covered a variety of domains, as you can see. If a person screened positive or a predicted high utilizer screened positive for a particular social need, there was an option to be enrolled into a program that was, that included program associates from health leads. The staff was actually, all of them were bachelor level recent graduates, a lot of them, and went through a health lead special training on how to interact with particularly our predicted high utilizers. We chose to use the staff, as Adam was mentioning, because we didn't necessarily have a dedicated staff that looked at some of the basic resource needs. We had social workers who looked at more higher level needs, and we often use them if a resource need became escalated to something that, for example, interpersonal violence became a root cause of why the resource need became an issue. So a lot of our work was done in partnership with social work, just because of that high risk that may be presented there. But essentially, if this was a general case, if it was a basic resource need, we would enroll the patient, refer them to a social needs resource organization that addressed that particular social domain within a geographic area that they recommended. So that could be their home, that could be work, that could be close to their child's daycare. They were able to select that. There was also an option if they felt that they were equipped enough to handle addressing the need on their own. We would do what we called a rapid referral of resource information, where the patient would be given kind of an express sheet of some sort, listing resources that could potentially fill that social need gap within the area they selected. So one option was more of, you have this kind of case management, you have a program associate who's walking you through the process, helping you with the application, helping you get transportation if needed to the resource. The other was more of we're going to empower you to address the need on your own. So we decide to look at 3 different geographic areas within this pilot. One, because the Southern California region has multiple medical centers. And we were really interested in looking at diverse patient populations and also different geographic areas. So we looked at the West LA area, which contains a lot of SPA 5, SPA 6 in LA. This is more of an urban area. This service area, really serves affluent areas as well as very low socioeconomic areas. We had Fontana, Ontario, which was in the Inland Empire. That region was selected particularly because of, one, the large high utilizer population that they had, but also the fact that we had been hearing that a lot of individuals from LA were moving to the Inland Empire due to cost of housing and other financial or economic issues. And then we also looked at Kern County, which was a very rural area, did not have a robust resource landscape, and we wanted to understand the challenges of working in those three areas. We decided to deploy a call center, particularly because we were working in three geographic areas. We decided to do a lot of front work at the beginning, meeting with case managers, community benefit officers, and community resources themselves within those areas to have a better understanding of the resource landscape at each area, and also trying to make sure that we had a connection point if in-person assistance was needed, but dealing with basic resource needs and also this ability to, if this pilot intervention were to work, have this opportunity to scale up. We thought that the call center was the right way to go.
Artair, can I jump in here and just ask, because I think you were getting a second ago as you were talking about choosing the different geographies. I mean, one of the big challenges that I hear over and over about these types of programs is the scalability, because each geography can vary so much in terms of their social service programs and their community assets. And so it's really hard to replicate. It can be really hard to replicate. And so given, Kaiser Permanente being so large and assuming this is, you want this to be replicable, how did you guys think about that? And I mean, you mentioned the call center as being one thing, but maybe you should talk a little bit more about kind of how you're thinking about replication and scale.
Yeah, I think that the three different geographies served as a great reality check of how nuanced a social needs intervention would need to be to reach multiple populations. And we were seeing those nuances even within a geographic region. So the approach for Fontana and Ontario, we could not treat every patient as the same as much as we wanted to. So we really settled on, and we'll talk about this a little bit more, but really trying to have standardized entry points. So making sure that we had scripting that seemed to resonate with multiple groups, but then realizing that the actual referral pathway or may need to be tailored. And I can give you a real example of that. Kern County, for example, the county was definitely more rural, had less resources than the other two geographies we were looking at. So we had to do a lot of kind of community engagement work with different CBOs to allow them to understand the pilot program, understand what was the easiest way to connect an individual to their particular organization. What does follow-up look like for that particular resource? And we didn't necessarily have to do that with West LA, for example. I think that geography and the CBOs that were present within West LA were used to people coming to their door and receiving a flood of of referrals. So we were just another group that was referring. And since this was coming from Kaiser Permanente, there were not a lot of questions that were asked. But when it came to Kern County, we had to think through the capacity on the CBO end, which is something that I think is often forgotten. So that's one way that the nuance came up. I hope that answers your question, April.
Yeah, that's really helpful. Thanks, Artair. And Marie just let me know that there's a number of questions, I think, that have come in through the Q&A and maybe through the chat. So Marie, do you want to maybe share some of those that we might be able to get to them? Yeah.
Yeah, absolutely. So we have a question from Anna Keen, which is, when you say that the time frame was 14 months, is that the time frame where you tracked utilization measures or the time frame for seeing a return on investment?
Yeah, good. So good question, and apropos to, I guess, our kind of study design here. So we used propensity weighted difference and differences approach, which means that these were all predicted high utilizers. We can talk, there's, a detailed other group, and Anna Davis, another researcher here, who kind of helped come up with the predicted high utilizer algorithm. But bottom line is, we looked at the 14 months prior to beginning the intervention, and the differences between the 3 pilot groups as well as all other 12 KPSC medical areas. So they were predicted high utilizers in all. And so we had 12 kind of control groups. That was a much larger control group that we used. And so we used the 14 months to do a difference and differences analysis on utilization, which was kind of both our primary outcome and kind of our ROI in terms of our primary outcome.
Great, thank you. We have another question, which was, how was the screening tool developed?
Yeah, I'll say one thing, and I'll let Artair, who spent more time in development. So when we first did this, as you know, the timeline was back in 2015. So we didn't have the CMS measure. We have a new, something called the Your Current Life Situation Screener that's being used frequently in Kaiser Permanente nationally, as well as in Southern California. So we tried to find the best validated screening questions that were available at that time, and that's kind of progressed a little since then, but that's what we did.
Yeah, Adam really addressed the question. We looked at each domain and looked at screening tools that really targeted that domain. There were some things, for example, like social isolation, caregiver support, those domains where it was harder to find a validated study that utilized a question that was targeting caregiver support. So we decided with those groups to really talk to different experts. So those were individuals who either were involved in the social determinants of health space to get advice on how to ask that question. And we also talked to frontline staff to get their expertise on how does this come up, what's the best way to ask this question. After we completed the screening tool and actually had the program associates administer the screening tool, we'll have weekly pull-ups with those, with the program staff from health leads to start asking about acceptability and usability. So how was it administering the screening tool? What questions were they seeming to trip up on? And then also, what questions were our patients struggling to answer? And in some ways that led to some slight revisions in wording to make it easier for both the staff to administer, but also the patient to be able to answer the question.
And this is just kind of building off of your answer, Artair, but who is actually administering the screenings? The Kaiser navigators, providers?
Yeah, so it was the health leads program associates who they had to go through kind of this co-health lead Kaiser Permanente training. So we were trying to provide them resources from Kaiser Permanente for training, and then Health Leads was also supplementing with their own training, but they were for Health Lead staff members who were doing the bulk of the administering of the screening tool.
And I'm just going to jump in and say I did notice a couple questions. One, I think on the Q&A, and then another on the chat about kind of methods of predicting high utilizers. And I'm going to suggest that maybe we hold that and circle back to it a little bit later, because I just want to make sure we can move through kind of the next section and also have time for questions there. So let's hold on to that one, but there were at least 2 people that were asking about that.
Adam, are you going to talk about that a little bit?
Yeah, I'll just address this. Everybody.
Okay.
I'll just say maybe a brief blurb about this, because we get a lot of questions, because everybody, we'd all love to be able to predict who is going to be a high utilizer. And I would say we have not mastered that. This is not a perfect algorithm. And I think for all intents and purposes, our control group were our predicted high utilizers in our control areas, and our intervention group was our predicted high utilizers. Obviously, there's been a lot of questions about, is 1% the right group? I mean, that may have been our issue, right? Because it might be at the margins, that 1% group are already kind of going to be high utilizers. Maybe we should have stuck to the top, like somebody in the top 10%. Maybe the 10 percentile was the group that we could actually have some benefit in. So I think for our purposes, this wasn't a perfect answer, and we have some algorithms that have subsequently been refined. So the one that we originally used is not the exact one that we use now. But the short answer is we know that past utilizers aren't necessarily always the next utilizers, and that's why we use the predicted high utilizers. But at least within our intervention and control groups, those, I guess, limitations were equally distributed, and so we felt that was okay in this particular. And I can refer you again to some details afterward about exactly how that was calculated for this.
Great, thanks so much.
I think that's a nice intro, Adam, into this next slide, if you can see it, talking about the study design. Yeah,
and so I mean, I've already kind of gone over this a little bit, and so we can answer more questions. But the punchline is, and I will say this: I obviously spend most of my time doing research, and so I'm biased in this regard. I think one of the key issues with a lot of these types of interventions is they have not been thoughtfully designed. They have not come up with the specific populations and a potential comparison group before actually intervening. They kind of start doing something, and then at the end of that something, they want to see if it worked. And that's just not a strategy for success as we try to calculate an ROI or whatever you hope to change. And so we, from the very start, we knew we were going after the high utilizers. We were going to look at cost and utilization. We ended up focusing on utilization as the primary outcome for the reasons I mentioned earlier. We also thought it was really important just to describe the patients. A lot of this was just descriptive. Within our large organization, we know a lot about our members. We didn't know which of them actually had social needs, in particular this high utilizer group. And so just defining that and describing that was helpful and a good place to start. We'll talk a little bit about the voltage drops later on, but those who were, we were able to contact by phone, that were screened, that actually agreed to participate, that we were actually able to connect with needs. We learned a lot based on each of those steps. And then, Artair already addressed a little bit that there are differences in the regional and geographic. This is local work. This is stuff that has to happen, I think, to have success at the local area. And different areas have different challenges and resources. And so what one area is able to do really well may differ from others. And so, we learned a little bit about that. And so this was set up again, at least to be a propensity weighted difference in differences analysis. The propensity score, we threw all the things that we thought we could into that, including all the comorbidities, age, race, gender. We have, census tract level information about their possible income and or education. And so we tried to, of the measurable variables, we tried to include everything that we could so that we could at least adjust for any potential differences using that strategy.
So, April, did you have questions after that, or okay, cool. So after going through screening approximately 3,000 predicted high utilizers, we were seeing that the highest prevalent need was around financial strain, and a lot of things that were also high came from financial strain. So the next highest was individuals saying that their food didn't last. We saw that with utilities. Assistance was a high social need. What also became really interesting is understanding this smaller group of caregivers who often mention the need to have support. Now, the reason why we have to put caveats around it is only 12% of the pilot population identified as caregivers of someone who was physically or mentally ill, but half of those individuals said that they needed some type of caregiver support. And so finding resources that both accommodated kind of equipment that may be needed for their loved one to just emotional support was something that we did not necessarily go into thinking about. So a lot of the needs that we were identifying, we kind of did some preliminary mapping to what resources they would need. And so with the caregiver support social domain, there were a lot more resources that tied into that particular need domain that we did not think about. So if you're going to ask about caregiver support, I think one thing would be helpful is talking to caregivers about the range of need or the range of resources that they would need to make sure that you have an appropriate resource database to kind of fill in some of those gaps. But so many of the needs that we saw were very much financially motivated, and we saw that throughout the entire intervention. Adam, is there anything else you would like to add to this? Or?
No, I think that's a good summary. I think one of the things we also got to, the overwhelming, when we first saw this, we all expected there to be a high prevalence of needs. And here, I don't think we show the cumulative, but this represents, some people had many needs, as was mentioned, related to financial strain, but 55%. So the majority of the patients that we screened at this 3,000 had at least one of these social needs. And this is a group, again, we're talking about Kaiser Permanente folks. This is not, county health system, which where people may expect higher needs. This is it was extremely prevalent. And so this was an eye-opening thing, just purely the prevalence of these things was something that was eye-opening and has led to a variety of other, initiatives in terms of our organization, both locally and nationally, to do something to address this. So this was really helpful and not terribly difficult. This is just percentages of social needs, but there's a great need is what we learned from this.
And I will say, on average, most patients had around 2 to 3 needs we were seeing. So as you think about staff and the caseload that the individual have, they were working with individuals who would have 2 to 3 needs apiece.
And one of the things we haven't, in terms of screening and in terms of kind of the iterative process that Artair talked about, this underwent, is we did ask at the end of, patients who had 2 to 3 or more needs, we'd let them prioritize which to approach first. Ideally, we address all of them, but we let them decide which of these was most pressing, so that we could start with that and work our way down.
Yeah, and as we started to do more work, we also started to try to understand maybe how we could bundle some needs together. We'll talk about that a little bit when we talk about bolus drops. It was a huge learning of understanding maybe how to, sometimes an individual does not qualify for a particular resource. So financial strain became a prominent or a prevalent social need. However, a lot of the resources were income-based. And so you had a lot of individuals who may not qualify because they make too much money, even though they feel like, even though they truthfully may not have enough money, they do not qualify for the resource. So we had to really think through how do we, a lot of times it was pivoting, understanding maybe this person doesn't qualify for this need, but is there another resource that may help address financial strain? So we started really understanding how do we point to resources that deal with financial counseling, or if a person didn't necessarily qualify for the transportation service, can we help them qualify for a utilities assistance kind of package, because that was an easier or a low lift connection. So it was a resource that really went through maybe your electric department, and they had the capacity within their organization to quickly meet that need. And we saw that sometimes that would offset another need. And we'll talk about that a little bit more, but we really started to try to understand what it looked like to have a bundled approach to addressing some of these needs, because we started off, I think, screening, if a person screened for a food need, and that's what they prioritize, but they could not necessarily get the resource they wanted, instead of saying, okay, that's just not a win for the patient, really coming back and going through with the patient, what are some of the other issues they may be having, and seeing if we could find a need that they qualify for. And again, we can talk about that a little later with the voltage drops.
And Artair, so there's some questions coming in, especially related to screening and the process there. So Marie, maybe you could share a couple of those right now.
Yeah, so there's a question here, and it's around the patients talking to strangers and how that may have affected your results. If you can speak to that a little bit, and maybe why you may not have chosen to build relationships with healthcare workers or other partners to make those conversations more comfortable for patients.
Yeah, we thought about that a lot. And we also did, Adam mentioned the focus groups and patient interviews that were conducted. And we specifically talked about that. And the feedback that we received was that they felt very comfortable talking to the program associates that we had. We really did not hear any feedback saying that they felt like the person was a stranger. There were a couple of things that we did to kind of make that happen. We made sure that the Health Leads program associates were part of KP. So they were introducing themselves as part of Kaiser Permanente. And I think that the Kaiser Permanente members there's a culture that you may hear from different people other than your primary care physician or even that nurse, that there are other people who are part of the care team. And so I think that culture actually worked to our advantage. But we also did a lot with scripting. So introducing the screening tool, and that's something we'll talk a little bit about with the voltage drops. And we saw a lot of improvement come when we were actually making social determinants of health an easier concept for a patient to engage with a healthcare provider on. So that was our initial issue, was why is the healthcare system asking about social needs in particular? Because that's not the space that healthcare systems have been in before. But there are a couple of things that we did in the scripting to, one, point to the fact that social determinants of health are a part of your health, and that's why we're engaging. But then two, we really developed this culture of we were wanting to screen for the common good. So you're part of the KP family, and we want to understand social needs as a whole for the entire KP population. And so the way we framed it is, hey, you're basically participating in the survey to understand if you have these social needs. And we're doing this for a lot of members. So we're not basically implying that we're not singling anyone out. But secondly, if it comes up that you may have a social need, we have resources available to you if you want to kind of work together to connect to a particular resource. So that was the approach that we took. Adam, I don't know if you have anything to add to that.
I'll just kind of summarize. Yeah, I'll summarize exactly what Artair said because he was spot on. I think the two really important key messages, because we weren't sure before we started this, but I think something that we learned over time was, number one, is that telephonic screening was as accurate and as good as any of the evidence that anyone has published that we've ever read about the warm handoff, somebody in the clinic, which is the typical health leads model. That was really surprising and really, really good news because it's far more efficient to do it from a telephonic place where you can reach thousands of people very efficiently. So that was very good news for us. So the concerns, we had all those same concerns, and the reality was maybe it's our system because they're used to being contacted by us. I don't know, there may be other things, but the reality is that was as good as the alternative, which is far more difficult. And number two is that in terms of scripting and in terms of working in this space, we had far more success when we said, we want you to help us, than we did, we want to help you. When we started this with, we want to help you by, addressing your social needs, we didn't get many people that were willing to enroll in our program. And when we said, we want you to help us to understand the needs of our members, and we want you to help us to improve the health of our communities through this thing, a lot more people, those same people that declined initially, were willing to enroll. So I think that those are two key messages, is that telephonic was actually really effective. And number two, asking people to help you, even though you want to help them, was a much better approach.
And also realizing that was connected to something bigger than themselves was a piece of feedback that we were hearing, as Adam was mentioning. It was definitely great for us to take this approach of the patient helping us as the healthcare system, because I do think that sometimes we take a more paternalistic approach. But the notion that they were part of a community and that this was helping the overall community was something that seemed to really resonate with our patients. And I think that that's just this desire to participate in common good that's just, within people that actually work to our advantage to see high screening rates.
Great, thanks. So let's move to the results and the voltage drops we keep hearing about, and then we will circle back to some of the other questions.
So this is pretty simple. I think you can see kind of our model at the bottom of the screen here. So sadly, our overall pilot was a null effect. So if 0.05 was our significance threshold, we didn't quite meet that, but had what was a hopeful trend. If researchers, we don't like to say trends if it doesn't meet our significance. But as you can see here, in our subgroups of people that were likely to be in need to have social needs, that were our Medicaid, as well as our dual eligibles, had much larger effect sizes that were significant. We are in the process. This has been submitted and is being reviewed for publication with all of the details. But I will also mention here that when we looked at groups that were likely to be have low education as a result of their zip code and address, or to be low income as a result of the same census tract level information, that we had similar effects as the Medicaid and dual eligibles. So, one thing here is that we didn't take this as failure, even though we didn't meet what we'd hoped. But maybe speaks to maybe 1%ers are not the best group, and maybe you target a group that is more likely to have disadvantages or social needs in order to have larger effect size. But this was our overall effect.
And also, I think, Adam, just to add on, and you can push back on me if you don't feel like this is fair, I think looking at some of the place-based metrics that we've been exploring also really shows, I guess, two things. One, how important it is to really understand the local context, and when you design your intervention, making sure that you are truly embedding yourself in the local context, understand the issues and the problems and the resource landscape there. But it really shows the potential that this has within some of the more marginalized or disadvantaged local places, if that makes sense.
Yeah, and it looks like I just see one question that popped up here. Utilization was everything. So for our members, we're fortunate to have a data set that looks at within our network. So anybody that came to our clinics, EDs, or hospitals, we also get claims information for any claims for our members who went to any outpatient, anything. So this was outpatient care, ED care, and hospital care. So I think that's it. Maybe should we jump to the voltage drops? This is this place. I will also mention, so as we get to the voltage drops, but related to the overall effect here, you're going to see that the number of patients that we actually were able to connect to a resource were very few. One of the hypotheses amongst my colleagues and researchers in this realm is that there may be something in the process that is actually beneficial to the patients beyond just connecting them to their resource, whether that's improving their self-efficacy, whether that's activating them as a patient activation measure. I don't know. We don't know exactly what that is, but the fact that we saw these effects in the screening intervention process, despite, as you can see here, only being able to actually connect, less than 200 patients with an actual documented met their need, is unlikely as far as the methods go here. And so you can see the voltage drops, but I think there's work to be done here in every space. Maybe I'll stop and let Artair kind of give his take on this, because I think there's a lot of learning that can be had here. We talked a little bit about the screening and the screen positive that didn't want to enroll, and I think the approach that one takes is really important. But there's drops here at every level, quite a bit.
Yeah, I think that with the voltage drops, we had to start to understand what was causing those voltage drops at each point. I believe a lot of the patient interviews we had gave us great insight on why we were seeing voltage drops. So, for example, with addressing the numbers screened, we talked about a change in the scripting language earlier. We also had to start doing time studies of when was the time of day to best call. Closer to the end of the intervention, to actually reach more patients, we tried to introduce interactive voice response, so using technology to do some of the calls, and we're actually seeing some favorable results. When we look at kind of the whole addressing enrollment, one thing that we learned, and this may be just with Kaiser patients, but it could be within your system as well, is we did a lot of scripting around enrolling in a program, and we learned a lot about patient burnout from being enrolled in another healthcare program. It's a case management program for everything. If you're diabetic, if you consider a high utilizer, you have a case manager for this, you have a case manager for that, you have a case manager for this. When we really started softening the language around enrolling in a program to really explaining the assistance we want to give, that we want to help prevent maybe social isolation from becoming a problem in the future, and also providing some options on how they could engage. So it could be, let's reach out to you. Can we give you some resources and then check in with you a month later, instead of the 2 weeks that we were traditionally doing? That seemed to get more people engaged. And then we really started to understand the importance of motivational interviewing. So really making sure that as we were enrolling, and I use the word enrolling, but getting people to engage with the program, that we're trying to get the individuals to talk about barriers as quickly as possible, and understanding, you know, how we could address some of those barriers before we actually got to the social need itself. And we really started doing that because it's important, you know, Adam talked about a lot of the outcome measures that we were collecting, but we would not be able to make those changes if we did not have put a lot of time in understanding the process measures that go along with the social needs intervention. So understanding why people were declining enrollment actually allowed us to have an entry point to understand these different enrollment options that people could have, because we were thinking that, you know, that the person may not have had time or that they felt like they were ineligible, but the largest majority was that people just were not motivated. They said they just don't want to enroll in the program at the time. Like, I guess at that point in time, there were 35% of individuals who declined enrollment who just simply said, we just do not want to participate. So I think it's really important for us sometimes not to have those pull-ups, to not make assumptions of what the patient is thinking, but making sure that we're engaging with patients as much as possible. And then for understanding how to create successful connections, especially using a telephonic approach, which I will say had challenges. You know, the biggest success we saw was with screening. The biggest challenge came with connecting to resources. But again, as Adam was saying, it was really comparable to what we saw in literature to how people were connecting to resources. But with the telephonic model, we actually started to explore having conference calls between the patient, the program associate, and the community-based organization. And we started to see some wins with that because the patient felt like they had an advocate on the phone with them. We also tried to, as we started talking about resources, we made it like an appointment, saying, hey, we've connected to this resource. Here's the individual you can talk to. They're expecting to meet with you at this exact time, at this exact date. And the last thing we were exploring was really coming up with a pathway playbook to understand how we can map the need to the actual resource within that particular area. So I know I threw out a lot at you, but we really try to do a lot to understand operationally how we could address some of those gaps. But I think, as Adam was saying, we were able to see movement in the major outcome of utilization through just screening individuals and getting them engaged. But I do believe that we could potentially have seen more if we kind of would have thought through some of these operational things.
Yeah, thank you, Artair. That's really helpful. And there's a couple comments and questions I think that relate to what you were saying. I mean, someone was wondering if the results might be statistically significant if the time frame was longer, perhaps. And there's some great questions that have come through. I think we're just about out of time. So I believe Marie is going to share contact information for Adam and Artair at the end. So so all of you are welcome to follow up with them directly if you didn't get your burning questions answered. But I do want to close with a really great comment that really resonates with me as well, that someone, Jane Chung, typed in, which I really appreciate. So it just says, not a question, but a comment. Thank you for being open about sharing results that weren't necessarily a resounding success. I think the more health systems are open to sharing learnings from pilot programs, whether successful or challenging, the more we can all collectively work to improve the health of our community. So yeah, I just wholeheartedly agree with that, and feel like sometimes we actually even learn more when things aren't successful. So just want to thank Artair and Adam really for sharing their information and also for being willing to have people potentially follow up with you with questions. Yeah, and Marie, is there anything else you want to say to close us out?
Yeah, I want to say a big thank you to you and Adam and Artair for presenting. I'm also going to pop up a quick poll. It should come up on your screen. This is an anonymous poll, and it'll help us understand if the content that we're providing is useful to your quality improvement efforts. Again, thank you so much to our presenters. This webinar was recorded and we'll post it on our website within a week. I'll also send everybody who registered and was on the webinar today an email with the link as well as contact information for Adam and Artair. We are looking forward to having you all on our third and final webinar with Partnership Health Plan of California on December 18th. The registration is open and live, and that can be found on our website at www.chcf.org/CIN. Thank you all again for this webinar, for those who attended and for our presenters, and I hope everybody has a wonderful rest of your Friday.
Thank you.
Thanks, great, thank you.
Thank you.